So record.
Yes.
Okay, guys, thank you. Can you see my screen, guys?
Yes.
Yes? Okay. Thank you, everyone, for coming. We have been doing EP conferences on a routine basis, roughly once every couple of weeks, okay? For those who are new, we do have educational platforms in Arabic through Instagram, focusing on inherited channelopathies or arrhythmias or cardiomyopathies. So please share with your patients. And then we have a YouTube channel where we recorded and uploaded our previous EP conferences. And then I'm a little bit active on Twitter as well, but more for case presentations and discussion with experts. Okay, so today we will present. We have our routine EP conference, and hopefully we will upload that presentation into YouTube. Okay, so I will. This is an interactive conference usually, so I would appreciate people not to be shy and please chime in and let's try to analyze the ECGs that are shown. Okay, so that's case one. This is an 8-year-old patient with palpitations, and it's relatively simple ECG. So the question is, what rhythm is the patient in? And you can speak up, guys. You can also use the QR code, but for time's sake, can someone volunteer and try to let me know what does she or he think of that ECG?
Flux SVT.
Okay, Sahar, what did you say? SVT?
SVT, yes.
Why do you say that?
Narrow-complex tachycardia. I couldn't see B wave.
Okay, so narrow-complex tachycardia, regular.
Yes.
P waves are not well seen, صح?
Yes.
Okay. Anyone has any disagreement, guys?
No, I think SVT assassin.
Okay, guys, try to mute yourself, please, if you are not talking. Okay, Mitwali, can you mute people?
Okay.
Yeah. Okay. Okay. So I agree. Mitwali, can you? Okay. So like Sahar, excellent, Sahar. So you said it's SVT because it's narrow complex tachycardia without clear P waves. Okay, so that's exactly the definition of SVT. So again, if you remember from last time, I did show this algorithm that I made myself. So this is an example of tachycardia that is narrow. You see my pointer, right, guys?
Yes.
Okay, and it's when you have a narrow complex tachycardia, you have two main differential. Is it sinus or SVT? Okay, if it's sinus, you should see P wave, normal P wave, i.e. normal P wave axis, and I'll discuss that in a minute. And if you don't see P wave or P wave that is abnormal in morphology and axis, then you should wonder about SVT. Okay, so in this case, again, there's narrow complex regular tachycardia without P waves. Okay, so this is SVT until proven otherwise, and this is why Sahar said SVT. Okay, when you in addition, when you suspect sinus tachycardia, usually the rate is less than 220 minus age. Usually there is a reason for the patient to be tachycardic, for example, febrile, anemic, in pain, crying, so forth. The rate is usually fluctuating. And if you have the onset of the tachycardia, it's usually gradual in onset and so forth, okay? So there are many hints for sinus tachycardia that you should look for before calling an ECG sinus tachycardia ECG. Okay, so this patient obviously had no reason for the heart rate to be fast, plus the heart rate exceeds 220 beats per minute. Okay, so it's very, very, very likely that it is indeed SVT. Okay, so again, definition of SVT is regular, narrow, complex tachycardia that is non-sinus. Okay, in brief. Okay, so when you diagnose someone with SVT, Then the next question is the patient stable or unstable? If the patient is stable, which is 99.9% of the times, it's almost always the case, then you have to record the ECG and administer adenosine or do a vagal maneuver, but you have to do continuous ECG recording pre, during, and post. I cannot stress this more. So please, please, please do ECG continuous, like rhythm strip, pre, during adenosine infusion or bolus, and post adenosine. Okay, I don't want ECG pre and then ECG after. That does not help me as much. We need a continuous ECG recording during adenosine administration. And believe it or not, I do say this all the time, but half of the time people don't do that. Okay, so that's very simple, and you have to do it. Okay, I mean, and then if it's an outside hospital, you have to give them that instruction. Okay, if the patient obviously is unstable, which is very unlikely, then you have to cardiovert the patient. Okay, questions, guys, so far? Am I too quick?
No, it's okay.
Okay. Okay, so when you give adenosine, obviously make sure it's a large IV cannula with a big flush, 3-way stopcock preferably, and a good dose of adenosine. Don't be shy of giving, don't give a low dose of adenosine. It doesn't make much sense, okay? Give a very good dose of adenosine with large IV and big flush, okay? I almost always do 0.2 to 0.3 per kilo, and if not more, I don't do 0.1 per kilo, okay? So give good dose of adenosine, okay? Obviously, when you want to shock a patient because he's unstable, for example, if you think it's an SVT but a fib or flutter type, then just make sure the pads are more anterior, posterior, rather than up and right up chest and left lower chest. Okay, just the positioning of the pads might be important or relevant if you want to shock a patient after the diagnosis of flutter or fibrillation. Okay, just FYI. Okay, so that patient, adenosine was given, and then the rhythm changed. So what do you look for after a patient presenting with an SVT and terminating with adenosine? What would you want to look for after termination of by adenosine? Like, what is the main thing you want to look for?
Is it
Wolf Parkinson White?
Yeah.
Oh, but it's not good.
Yes, right. So terminates, obviously the patient went back to sinus rhythm.
Yeah.
And then your next question would be, is he Wolf or not? Okay. Is he in this case, yes or no?
Yes, he's. There's short PR.
Okay.
Some waves have wide QRS,
Okay.
but there is no apparent delta wave or slurring of the.
Yeah. So are you confident that there's WW, or
No, I'm just
may
suspecting that.
You are not, or you are?
Some waves have wide QRS, but others don't.
Okay.
And I feel the PR is short here, all through the ECG.
I mean, the PR, obviously, you have to, from the onset of the P, which is here, to the onset of the QRS. So it's roughly 120 millisecond, which is, it's not short. The PR is
For
not.
an 8 years old, it's.
I'm sorry?
He's 8 years old. 8 years old is the age you said?
Yeah.
8 years old, right?
Right. So the PR is not
So-
short. Is there a hint of delta? Maybe,
No, there's no
but
delta.
yeah, the PR is not short. Okay, but is there a hint of delta? I don't think so. I mean, remember that ECG is digitalized, meaning, it's a scanned original from the original ECG. Sometimes the digitalization just a little bit changes the QRS is just a slight bit. So so maybe this is what you are seeing, but definitely the PR is not short, and there's no clear delta wave. Okay, so I would not call this WW. I mean, it might, but I don't think there's WW. Okay.
Yes.
Furthermore, what when you see Q waves in V6, for example, V5, this is usually against WW. Okay, so the normal depolarization is through the septum. Okay, the septum
Yes.
depolarizes first, and the septum is depolarized from the left side to the right side, okay? So the left part of the septum is depolarized before the right part, okay? So usually the initial vector of the QRS is going away from the left lead, is going away from the inferior lead. So normally you see Q waves that are you see Q waves that are present in V6, V5, because we're going away from the left side, and you see Q waves in lead 2, 3 AVF because you're going away from the inferior side, okay? So with WW, the initial vector is different, so you might the normal Q waves position might be different, but in this case the Q wave on the onset of the QRS is all normal. There is no short PR, there's no delta, so I don't think there's WW. Okay, everyone agree or disagree, guys? Is there anyone has any disagreement?
No,
Okay, agree.
Okay. So, I mean, sometimes with in pediatrics, because the AV node is so good, it's sometimes the WW is so subtle. But in this case, I don't think there's WW. Okay. And I can't remember the patient whether we did EP study or not yet. To be honest, so I don't remember the patient that well. Okay. Okay. Anyways, okay. So so, and I said the patient is in sinus rhythm because the sinus, what's the definition of sinus P wave, guys? Really quick. I did mention this many times. How do you tell the patient is in sinus rhythm? What do you look for?
Upright P,
Where?
upright P in lead 1 and the AVF.
Okay. Upright P in lead 1 and AVF. I mean, just so you know, the sinus node is here. The atrial activation direction is towards the left side and toward the inferior side. So you see positive P waves in the left leads and positive P waves in the inferior leads, i.e. lead 1, AVF, 2, 3, and AVF. Okay, guys? So you're going towards the left, you're going towards the inferior. So all leads that are inferior and leftward, you should expect positive P waves. Okay, guys? Okay. And this is a nice example of a sinus, rhythm. Okay. 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 Case 2. Another 8 years old. This one is a more complex patient. She is a Fontan patient. This is a patient that just came into our hospital like 2 weeks ago. I don't know, 10 days ago. Abbas remember. So 8 years old Fontan who is complaining of palpitations. Okay. I don't have this 12 lead ECG. I have a 6 lead ECG. And just really quick, how do you describe that ECG, guys? I don't want diagnosis, just description.
Wide complex tachycardia.
Okay, wide, bad, regular or irregular?
Regular.
Regular.
Regular, wide, complex tachycardia. Excellent. Okay. Okay. So, I did show that algorithm in a previous EP. So whoever is new might not see. This is the first time you might see that algorithm. So the patient's tachycardic, has a wide, complex, and regular. Okay. And then, furthermore, monomorphic. Okay. So then your differential this is your main differential. So either sinus tachycardia with baseline aberrant QRS or baseline bundle branch QRS. Okay. Or SVT that is aberrant. Okay. Meaning SVT with bundle branch block. Or it's an antidromic tachycardia, meaning you're going down an accessory pathway, up an AV node. So you have a wide complex rhythm, or it's VT. Okay, guys? Agree? Understood?
Yes.
Okay. So, excellent. So what do you think our next intervention should be? The patient is stable, by the way.
Vagal maneuvers or adenosine?
Adenosine we can give.
Adenosine or vagal maneuvers?
Okay, excellent. So you want to do vagal or give adenosine. Then it's again
Regular.
SVT. Then SVT is SVT and antidromic tachycardia is in your differential. Okay, guys, and you will terminate them when you give adenosine. Okay. Okay. So this is what we did. So we did not have three-way stopcock. It was a small vein. And remember, she's Fontan, and we give 0.24 per kilo of adenosine here. Okay, what do you guys see? Anything happened or not really?
Nothing.
Not really.
Nothing happened. Okay.
No change.
Okay, excellent. So, you know, we now, so now, you know, what do you do next, you think? Are you going to call it VT or are you going to do something else?
Because sometimes in from 10 patients, the adenosine will not work.
Yeah, صح. So what do you do?
Yes.
So what do you do? Give a bigger dose.
Yes. I was thinking of it. Yes.
Okay. So we gave 0.36 per kilo. Okay. And then what happened? What happened?
Return to sinus.
Sinus
With
now, yes.
QRS.
Termination of the tachycardia into sinus rhythm, right? Okay.
Yes.
So now, knowing the differential, if you remember, we said SVT with aberrancy or sinus tachycardia or VT or antidromic SVT. Which one of those is the patient having?
Antidromic.
Okay, I hear antidromic. Anyone else has any other thoughts or agree or disagree?
Why not
Maybe
SVT with aberrancy?
No bundle branch block here.
maybe SVT. Don't know.
Okay, so Sahar is saying SVT.
SVT, yes.
I heard SVT. I heard antidromic tachycardia. Anyone has like anyone agree? Like anyone has any other thoughts or agree or disagree or? So Maya, you said antidromic SVT, right?
Yes.
So what do you think will happen? You know, antidromic SVT, you will have a wide complex tachycardia initially, right?
Yes.
When you terminate, is it going to be wide or narrow? Or is it going to be the same QRS or different QRS?
No, the QRS will be different.
Okay, now here, is it different or the same?
Different. Now it's narrow.
So you think that QRS is different?
Yeah, I think it's narrow. Not the shape. The shape it's almost the same, but
Yeah, the shape is almost the same. Remember during tachycardia, the you know, the heart shape is different. Plus, you know, there might be subtle changes in the QRS, very subtle changes, but predominantly that QRS is almost the same as this QRS, صح? With antidromic SVT, you will have a complete change from a very wide complex tachycardia, which is usually wide, into a very normal or much narrower QRS when it's sinus. Okay, so you'll have very change. Plus, you will have WW when it's sinus, right? Then you're going down and easy note. So you expect. Do you think there's WW here?
no.
No.
First
Not a
degree.
short QRS.
Okay.
But in the previous ECG, the QRS was wider. When you show
Remember
us
that. Well, it's what do you mean? I mean,
yes,
well,
one.
remember these are V1. These are different to me. V1 versus lead 1, 2, 3. So different ECG, different leads. Okay. Okay. So, you know, so Sumaya, you agree it's not antidromic SVT, صح?
Yeah, but it's not SVT with apparency, I think, because there is no
well,
apparent.
the QRS is almost the same, صح?
Yeah.
The patient has already intrinsic wide QRS because she's Fontan. I don't remember her anatomy, Abbas. If you remember, let us know. But she has a complex single ventricle. And so she has a baseline wide QRS, okay? But during SVT, the QRS is wide just because her baseline is wide. And during sinus, her QRS is also wide because her baseline is wide. Makes sense?
Yeah.
Yes.
Okay. Everyone agrees, guys? Is it
Yes.
this is a complicated tracing a little bit. Okay. So in other words, so you know, we gave her a higher dose and a more rapid flush. We did trick me and Abbas, and we you know, because we did not have three-way stopcock, so we did something, you know, and we succeeded. Okay. So the patient had usual complex tachycardia, pre and post adenosine is almost exact same QRS. So we're calling it SVT with baseline, you know, aberrancy. Okay.
But Dr. Muhammad, if there is a baseline apparency, there is no bundle branch block here in his normal after adenosine. So there is no bundle branch block C.
I mean, it's a white QRS, صح? Remember, she's Fontan, she's single ventricle, Sumaya.
Yeah.
Okay. So she has a white this is wide QRS for her, okay, for the patient. This is whitish, okay. She's only 8 years old. If you measure, it's
It's almost 2 or
if you
But-
measure, it's probably 120. It's a little bit beyond 120 or roughly 120 milliseconds, okay. So if you measure here, this is 1, 2, 3, a little bit more, maybe 140 milliseconds. So that's wide, okay.
Mhm.
Okay.
Oh,
So you have to
okay.
measure carefully, but it's definitely not, narrow QRS is usually the QRS are, the both the up, the both like the upward deflection and downward deflection are like kissing each other. Okay. There's no space between them. Whenever you see space, this is almost
Mhm.
wide in pediatrics. Okay.
Okay.
Yeah. Okay. So in other words, she has SVT terminated with adenosine and not VT and not angiodynamic tachycardia. Okay, agree? I mean, rarely you have VTs that are responsive to adenosine. So, we cannot rule it out like 100%, but we don't think so. And her anatomy is apparently unbalanced AVST with small LV. Okay, guys, everyone agrees, guys?
Yes.
Okay. Okay. So it's a little bit, and the rate is also just another note. The SVT. Sometimes when you read books and stuff, people would say SVT definition is above 170 or 180. There's an arbitrary number that people throw in, but that's not the case. Her SVT, for example, here is I don't know, it's like 130 beats per minute. Okay. So it's, sometimes you get SVTs that are 120 beats per minute, 125 beats per minute, 130 beats per minute, especially with complex patients, complex single ventricle patients, and patients on drugs to begin with. Okay. So the rate itself is never a definition. Okay. So in this case, we suspected SVT because she's having resting heart rate that is higher than her norm, plus without the preceding P wave. So it's not sinus tachycardia. And we know that her intrinsic heart rate, because she's already on sotalol, her intrinsic heart rate is usually around 70, 60, 80. She's on the slower side because she's on high dose sotalol. And she comes in with a heart rate of 130, doesn't make sense, okay? And no P waves, and we know her P waves are usually nice and big, okay? So it's not sinus tachycardia, and we suspected SVT, and indeed we gave adenosine, and we proved our suspicion. Okay, guys? Okay, so you have to have high index of suspicion. Generally, Fontans are usually bradycardic. When you get to see a Fontan and he's tachycardic, always suspect arrhythmia. Okay? Okay, guys? Okay, guys? Okay. Okay. إنزين. Okay, so I meant to talk about management a little bit because so many people want to discuss management. Okay, so in SVT in general, we always try to abort the SVT by giving adenosine. Okay, if it converts but reinitiates, this is why I want you to show me the rhythm strip during the adenosine, because some people will call me, we gave adenosine, nothing happened, but something happened but it was transient. Okay, so I don't, and I would love to trust each and every one, but many times I trusted people and then they say nothing happened, but something happened that they missed. So that's why I stopped trusting. I want to see it myself. Okay, so please, whenever you do adenosine, I have to see the ECG myself, because sometimes subtle changes happens that people miss. Okay, that's why we want to document the response to adenosine. So anyways, so if it converts but then reinitiates, that there is this an SVT, and the patient need medications to keep the SVT from occurring. Okay, so that's why you want to usually medicine that starts quickly because the patient is in SVT. So you want to do IV medication and immediately. Okay, so if the function is depressed, which is sometimes the case if the SVT is long lasting, if the function is depressed, I usually do combination amio and dig to help with the function. Amio because it's one of the safest drugs when it comes to decreased function. Okay, if the function is normal, I do esmolol. Okay, guys. And you know, the beauty, the esmolol is very nice drug because it's very rapid acting. You start, you know, you will see effect right away, and you can increase the dose quickly. And you know, if something bad happens, you immediately turn off esmolol and it goes away. Okay, so it's a very nice drug. I love it. It's just sometimes when the function is depressed, we might not be able to use it. Okay, so if it converts but then reinitiates, I always admit the patient, of course. I always start IV meds if you noted, and usually depressed, and I always ask for an echo. This is why. If it's all depressed function, do amio plus minus dig. If normal function is normal, do esmolol. Okay, guys? And then while we're giving IV stuff, we might give him oral flecainide, oral sotalol, oral something to speed up the process. Okay. 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 Anyways, if it doesn't convert, then obviously you might wonder about SVT. You know, the initial ECG was not SVT, for example, or there's a wrong technique, improper dose, low dose, and you have to consult people. So I showed you an example of an SVT that converted and an SVT that did not convert initially, but then converted. Okay, so very often the technique or the dose is inappropriate, and hence you want to revise the dose and the technique. Okay, but obviously if it doesn't convert, then you have to worry about something else. Okay, for example, atrial tachycardia, for example, junctional tachycardia, and so forth. Okay, and usually this is it gets complicated, and you have to involve experts. Okay, if when it converts after adenosine, then I usually admit if the patient is nonverbal, meaning he's an infant, 2-3 years old and sooner, or younger, because they are unable to communicate with their parents that they are having SVT. If I think they cannot communicate, then I usually admit for a day or two, just in case. Okay, but if the patient is able to tell, and the patient told the parents, I have palpitation, they went to the ER, there's an SVT, and we converted the SVT, I don't need to admit, because I trust that the patient will say, will complain about palpitation if it, happened, after a few hours. And I also try to educate the family how to screen for SVT, like by doing heart rate measurements, okay? Roughly twice or once per day, okay? If it's a neonatal SVT, we usually treat for 4 to 12 months, depending on which school are you from. If it's a patient that is 15 kilograms and above, then I give them the option for an ablation. An ablation option is possible. If the SVT is happening outside the neonatal period, like infancy and afterwards, I usually tell the family that that SVT would recur, and at some point the patient needs ablation, because it will not usually go away by itself. If it's a neonatal SVT, very often goes away by itself. But if it's beyond 1 year of age, usually the SVT will not go away by itself. Okay, so in that case, I treat. I don't wait for the second episode unless the family really wants. I usually treat, especially if the patient is nonverbal, until they are able to speak, and then they are usually by 15 kilos and above, and we offer ablation. Okay, if they don't want ablation, we can stop the medication and educate the family. If there's recurrences, you have to go to the ER and do adenosine, or pill in the pocket propranolol, or as needed propranolol. You want to give propranolol as needed and nothing else, because propranolol is a short acting drug. Okay, you don't want to give a drug that takes forever to work and they are in SVT, right? So you want to give propranolol, which is the shortest acting oral medicine. If the patient is in SVT, so okay, it helps lower the rate and stuff. Okay, makes sense, guys?
Yes.
Okay. And if the patient has SVT without WW, I always tell them that's not life-threatening, arrhythmia. You can do ablation, you can do medication, you can do pill in the pocket propranolol, or you can do nothing. Okay, if there is WW, then it's a different story. There's a risk of sudden death, and I push for an ablation. Okay, you know, I don't force, of course, but I always tell them there's a risk of sudden death. It's up to you, but it's what's recommended is to do an ablation at some point. Okay. Okay. And remember, with calcium channel blockers are contraindicated in infants, and DIG and calcium channel blockers are contraindicated in WW patients. Okay. 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 So dosages. I will not go through just this slide for your information. You can take a picture, or I'll post it on YouTube, just so people don't, you know, call me, what do we do, what specific dose, because you know, I don't have to repeat myself. These are the usual doses that we usually do. Okay. Just scan, read them really quick. Do you have any questions? Just so you know, we usually do propranolol for babies because short-acting medicine, and you know, if there is side effects, it would not, you know, last. You know, the medicine would, you know, be washed out of your body relatively quick. So I usually do propranolol for babies, and Q6 dosing if the patient is less than 4 months of age, and 8 TDS dosing if the patient is, you know, beyond 4 months of age. Okay. And if the patient is outside the neonatal or infantile, you know, period, I usually just go with atenolol. Okay. If I want to do beta block. Okay. Verapamil, I don't use very often, but only for difficult to treat SVTs and so forth. Digoxin usually is not a solo, you know, drug. And then I will not talk about flecainide and sotalol because these are usually you have to involve EP because it needs specific monitoring. Okay. But you don't need to involve me so much if you want to give beta blocker, if you want to give digoxin, if you want to give verapamil. Okay. And the IV medications are as such. These are the usual dosages that we usually do. And remember, SVT is not usually life-threatening, so don't be super aggressive with dosages because the, you know, medications might harm the patient more than the SVT. Okay, guys? Questions? Okay. So especially newborns, you know, you want to be careful with administering IV drugs because they might have hemodynamic collapse. Okay. So you have to be careful. Okay. Okay, guys. Okay, case 3. 1 day old patient had interesting patient. This patient had fetal tachycardia, unclear, and the mother was given flecainide, and then the baby was born. No flecainide was, you know, resumed, but then soon afterwards, like, you know, within the same day or I think the next day, patient became pulseless and had this ECG. Okay. Okay, how do you describe that ECG really quick?
Wide complex tachycardia.
Okay. And be
And
little
look
monomorphic.
regular.
quite
Monomorphic.
complex. I mean, I know it
Looks
looks
like VTech.
monomorphic, you know, in general, it looks monomorphic. I agree. But if you look very, very carefully, there's
Wide complex tachycardia. It's like a VTech.
yeah, so there's subtle changes in QRS's morphology, very subtle changes. So, I mean, I don't mind, you know, like, for example, if you look at, you know, AVR, you know, if you look at lead 2, there's subtle changes in QRSs. I don't know whether it's truly monomorphic, but I agree with you in like it looks largely monomorphic, and it's wide complex, and then you have to measure the RR intervals and figure out whether it's regular or irregular. It's again slightly irregular. Okay, slightly irregular. Okay. Anyways, so you have to know how to describe the ECG, because once you describe the ECG correctly, then you have a more appropriate differential diagnosis. So I think everyone agrees it's wide complex tachycardia. It's a little bit irregular. And if you look carefully here, for example, this RR interval is a little bit different than that RR interval. Just eyeballing it. You agree? You know, this RR interval is definitely different than this RR, right?
Regular, yeah.
Yeah. Okay. So it's subtly irregular. So anyways, so if you believe it's irregular, then you have this differential: atrial tachycardia with aberrancy, okay, AFib with WW, okay, or VT, polymorphic VT and VF. Okay. So you have these 3 main differential. If you know, remember the differential is almost always very brief. when it comes to tachycardias, okay? So you usually have a have a limited differential, which is nice, so that you are more able to correctly diagnose the patient, okay? Anyway, so you have this list of differential diagnosis, okay? Obviously, the patient, if you look at the QRS, it's very atypical for bundle branch block. It's very wide, very ugly looking. The patient is arresting, so you have to assume it's VT until proven otherwise. You don't have the luxury of, okay, I want to think about it, I want to give adenosine, I want to do, the patient is arresting, okay, is pulseless, okay? So in this case, wide complex tachycardia, unstable, you have to defibrillate, okay, guys? And this is what we did in our ICU, okay? Okay, and then when you want to defibrillate, just FYI, you want to, again, be appropriate in dosing. You want to give 2 joule per kilo and then go up, okay? Don't give 0.5 per joule per kilo or 1 per kilo, okay? You have to do asynchronous 2 joule per kilo of energy, okay, guys? Questions? Okay. Okay. I hear in the chat, not I hear, I read in the chat there is this is torsades. Torsades, in order to say something is torsades, you have to know the baseline QT is long, okay? You cannot be, I did not show you the sinus ECG, okay? Sleiman, I think it was it, or Nabil, I don't know, one of you, okay? Anyways, okay, so that's an atypical patient. So once we cardioverted him, he had Mobitz 1, and, his baseline was Mobitz 1, and he developed, and he had VT, he had a couple of VTs. Well, I mean, the VT had recurred a couple of times. We did genetic testing, was negative. We wanted to do whole exome sequencing, but the family we want to do it like through through private lab, but the family is not willing to pay yet. We did not do cardiac MRI. I mean, he was a newborn. So far we don't have a clear-cut diagnosis for that patient, and there is no family history to speak of. So the patient currently is medicated and probably needs an ICD at some point. He's only paced so far, and she's doing well. She's on beta blocker, mexiletine, pacemaker, and no VT, except she once was sick. They stopped her beta blockers, and she got VT while she's admitted with flu influenza B, So anyway, so she really likes her beta blockers, but I think at some point I don't trust beta blockers on her. We probably should upgrade her pacing to ICD. Okay, she's I think now 4 years old, 4 or 5 years of age. Okay, anyways, I will not, she's a complex patient. I don't even understand her so well. Okay, case 4. 8 years old, pale, palpitations, most of our patients are 8 years old. So pale, palpitations with pain, and the heart rate is obviously very rapid, okay? This patient presented to us like back in September. Okay, so what do you guys, what do you guys think, or not think, what do you guys, how do you guys would describe the ECG?
Also, wide complex tachycardia with irregular intervals.
Okay, excellent. So wide complex tachycardia, irregular. صح? Everyone agrees?
Yeah.
Disagrees? Anyone has any disagreement or is agreeing? Don't be shy. MashaAllah, Shema. This is Shema, صح?
Yes, yes.
MashaAllah, Shema is not shy. Everyone else is shy. Sahar is also not shy. Sumaya is not shy. But the rest, super duper shy.
It looks this is wide complex tachycardia, but I don't know, it's monomorphic sometimes, not very regular, not same shape.
Yes, خلاص. If it's not same shape, you just say polymorphic. Okay.
Polymorphic, yes. In some.
Okay. Everyone is insisting to be shy. Okay. So I agree. So tachycardia, wide and irregular. صح? Same differential. Okay. Same. We just talked about that differential. Okay. So this patient is not arresting. She's pale looking. She's not very comfortable, but she's not arresting. Okay. So you have a minute to think. So, Okay, so what do you guys think is the main differential in this case? I mean, is it VF?
I think AFib
was WBW. maybe.
AFib with WBW.
Yeah, okay. So I mean, this is a very, you know, this ECG you have to remember, you know, someone young with irregular wide you know, tachycardia, but you know, but not super duper unstable. One differential would be AFib with WW, okay? Especially if the patient, you know, there is no family history of, you know, not congenital, channelopathy or inherited arrhythmia, and you know, so AFib with WW is high in your differential, okay? So again, this is why it's irregular. You know, you have to look very carefully. Definitely irregular, and then the QRSs are different, okay? And then you see, if you see the onset, it looks very slurred, okay? Onset is almost always slurred, okay? And that points towards WW or antidromic tachycardia, okay? You're going down to the ventricle outside the Hesperonychus system. So if the onset of the QRS is sharp, usually this indicates you're going down to the ventricle through the through the Hesperonychus system. If the onset of the QRS is very broad, then this indicates you're activating the ventricle, not through the Hesperonychus system. Makes agree, guys? Okay, understood? Okay.
Yes.
Yes.
So, you know, the patient again has no congenital heart disease, no genetic heart disease or inherited arrhythmias. There's initial slurring. You know, obviously, pre-excited AFib is high in your differential. So, Manal, I think, was on call. She's not here, I don't think. Anyways, she's on call, and they called her from, I don't remember where. Maybe, I don't remember. Anyways, they already gave adenosine twice, and then they called Manal. So do you guys agree in giving adenosine?
Contraindicated. I think. In irregular, it can go to
Yeah.
ventricular fibrillation.
Yeah, so don't give adenosine if the rhythm is irregular, as a rule, okay? So you should not do that. You know, you're risking the patient of going into VF or more rapid, you know, ventricular rate and then inducing VF, okay? So if something is irregular, don't give adenosine. Adenosine you only given for regular rhythms, okay? You know, adenosine is not a joke. You have to, sure, you can use it all the time, but you have to be smart and use it wisely and use it for regular rhythms and stable rhythms and not irregular rhythms, okay? So, so indeed, the patient, so, you know, so this is in my, so when you encounter a wide complex tachycardia like this case, and the patient is stable, ask yourself, regular or irregular? If it's irregular, you know, most of the time you need to do cardioversion. I mean, if you want to, you know, if the patient is stable and irregular, you can also, you know, we can discuss the case, and if we think it's pre-excited AFib, some people may give procainamide, but we don't have procainamide in Kuwait. I don't know whether you have it, like whoever is attending, you might have procainamide in your country and you can consider procainamide, but in Kuwait, we don't have procainamide, just cardiovert the patient, okay? And this is what I told Manal, tell them to cardiovert the patient and stop giving adenosine, okay? So and then if you go to PALS, you know, if you read carefully, if there's a wide QRS in the, okay, consider adenosine if the rhythm is regular. So regular, monomorphic, you can give adenosine. Otherwise, don't give adenosine, okay? So you have to be careful. So the patient was not cardioverted electrically, was just vomited and then, you know, rhythm changed, okay? So she had her own vagal maneuver, vagal, you know, response. And this is what happened. So what are we seeing here?
Short BR interval and the delta wave.
Yeah. So the patient had
WBW.
okay. So confirming it was pre-excited AFib. Okay. Obviously, if you think it's pre-excited AFib, when you cardiovert, you want to see WW, like the antidromic SVT Sumaya, you want to see WW afterwards. Otherwise, it's not. The diagnosis is not correct. Okay. Okay, so there's clear WW. Okay. I don't know whether we have how many slides I have left. Oh, sorry. Okay, we're almost done. So we have time. Okay, just really quick. With WW, it is you have an antigrade only or bidirectional accessory pathway, and hence your PR shortens because your accessory pathway conduction time usually is shorter than your AV or his conduction time. So in other words, if you have an accessory pathway here, for example, usually the sinus node obviously activates the AV node and then goes down to the ventricles. Okay, that time is almost always slower than the accessory pathway, than the time needed for the accessory pathway to conduct electrical activation down to the ventricle. Okay, hence the PR shortens, which is defined as the time it takes for this atria to activate the ventricle. Okay, so the PR shortened because your AV conduction time is shorter because your accessory pathway conduction time is often faster than your AV node conduction time. Okay, guys, make sense? Okay, agree?
Yes.
I know I'm a little bit
Right.
fast, but because I want to stop at 8. Okay, I want to try to keep it in keep the be mindful of the time. Okay, and then why do you see delta wave? Because the that accessory pathway pre-excites or activates a piece of myocardium prior to your normal septal activation, and that activation is not through his Purkinje system. It's going cell to cell, cell to cell, cell to cell. So you have initially a slurred onset of ventricular depolarization before the his Purkinje system takes over, and then your QRS normalizes. Okay, so you have initial slurred QRS because it represents your ventricular conduction outside the his Purkinje system. Okay, guys. Okay, so that red piece of myocardium represents the delta wave, and that green normal septal myocardium and everywhere else represents the rest of the QRS. Okay, okay. And why do you think the axis is changing in? So, for example, this patient has left axis deviation, right?
Yes.
Okay, why do you think that is?
Because the conduction is starting from the right side. It's right of the heart. So it's going to the left.
Because just
A
simply
long time.
because normally the QRS axis is a function of your his Purkinje system, activating your septum and then mainly your left and right ventricles, right? So you're going normally this way, okay, if you are not a newborn, because your left ventricle is the predominant ventricle and it's on your left side and posterior side, okay? So you're going towards the posterior leads and towards the left leads. That's normal. Now, if you have a competing depolarization, the axis might shift according to where is that competing force going through and from. Okay, so whenever you have a W, very often that axis would shift because you're not activating your ventricles you're not activating your ventricles normally anymore. Make sense, guys?
Yes.
So when you see QRS axis abnormal, one differential is always WW. Okay, so when you see axis abnormality, you always have to ask yourself, is this WW that we're not paying attention to? Check the PR, check is there delta wave and so forth. Okay, so always, not always, but many times with WW, your axis would be different. Okay, furthermore, so this patient, if you look carefully, the patient has Q waves in the inferior leads, right? Like ugly looking Q waves, right? So does the patient have like inferior MI? I mean, has Q waves in V1, for example? Does the patient have inferior MI, you think, or is it, why is that, you think? Difficult question, but again, it's the same concept. You know, your Q waves are normally as a results from your septum being depolarized. Okay, and like we said, so by the way, Q wave is just defined as negative deflection that precedes an R wave. Okay, normally it represents your septum being depolarized. Okay, and the septum is depolarized from your left ventricle side. Okay, so you're going from your left ventricle to your right ventricle. In other words, your left ventricle, which is posterior, and your right ventricle, which is anterior. So you're going posterior to anterior direction, left to right direction. Okay, so you're going away from your inferior leads and you're going away from your left leads. So that's why you see Q waves before an R wave, because you're at the onset of the QRS, you see QRS is Qs at the inferior leads because you're going away from the inferior leads, and you're seeing Q waves in V6 because you're going away from V6. Make sense, guys? Well, it's too confusing.
It's okay.
Okay, so now you have WW. The septum is not depolarized first anymore, صح? Wherever that accessory pathway is depolarizing a piece of muscle before the septum, صح?
Yes.
Okay, so now it's normal to have the different abnormal looking axes plus, Q waves, because the Q wave is not anymore representing your septum now. Okay, so in other words, when you have WW, your QRS morphology would change dramatically. You might think the patient is having MI, is just having double accessory pathway that might mimic MI. The depolarization is completely different. Okay, hence your ECG might look very different than normal, and some people might think the patient does have an MI, but it's just WW with short PR and delta wave, and the QRS looks funny just because there's an accessory pathway that is ruining your normal depolarization. Okay, plus whenever you have depolarization that is ruined, your repolarization might also be affected. So you might see, ST segment changes, for example, a segment elevation, a segment depression, and so forth. So whenever you have QRS that's messed up, your repolarization would just look abnormal, not because the patient is ischemic, just because everything is messed up. Okay, because it's not normal anymore. Okay, guys, make sense?
Yes.
So you cannot overread. Whenever you see WWECG, you cannot interpret that ECG much further. Okay, you cannot, if you think there's true ischemia, you have to rule it in or rule it out by CT, by echo, by troponins, by something else. You cannot rely on the ECG. Okay. Okay. So okay. So your repolarization is also abnormal, just because your depolarization is not because there's true repolarization disease or true ischemic disease. Okay. So managing the atrial preexcited atrial fibrillation is first of all, it's life-threatening, and this is why WW patients might die, because they get that preexcited AFib, and then the ventricle is going rapid, like for in this case 350 beats per minute, and then at some point this might degenerate into VF. Okay, it's not, luckily it doesn't happen that often. It happens, the risk of this is happening is around 1 to 2% over lifetime of a patient. Okay, so whenever you document that rhythm, the patient need to be ablated, because she did that already, so she will do that again, and you cannot trust only medications. Okay, so usually you want to ablate the patient, and this is what we did for that patient, and the patient was ablated, and then 2-3 months afterwards was discharged from clinic. And if just this is not it's okay if you it's not very, this is advanced, but if you see that's WW is QRS, and that's normal QRS after an ablation. Okay. Okay. So anyways, but in this patient, this is what we did. We ablated the patient, and and then the patient was discharged. So we did not even start medications, okay? The same admission, did not go home, scheduled an ablation, did the ablation and went home, okay? Okay, anyways, last case, I think, case 5. Okay, Natalia is asking a very complicated question, asymptomatic WW. Natalia, asymptomatic WW, if the patient is at an ablation age, we almost always still offer an ablation, even if it's asymptomatic, because of that, that pre-excited AFib might happen suddenly. Like, for example, this 8-year-old patient that we just saw, she was asymptomatic prior to that. And she just presented with this for the first time, okay? So sometimes the first symptom is deadly, okay? But there is another topic that is, debatable. If the WW looks very weak on stress test and Holter and so forth, are they at risk of sudden death? They are still at risk of sudden death, but less than, those who have not weak WW. So those patients, people still try to ablate. Some people try to avoid ablation. So, it's a little bit debatable, but most people will still try to ablate most WW patients, okay? Okay, case 5. So I don't have an ECG. I have...
Sorry for a question here. If patient refused ablation and we put on beta blocker, does this affect the incidence of sudden death or?
Well, if you have to do medicine, you want to give flecainide. Flecainide might affect your accessory pathway antegrade conduction. Beta blocker usually doesn't affect the antegrade conduction, okay? Flecainide, you want to give him, good dose flecainide, and this might reduce the risk of sudden death. But otherwise, this is your best drug. If you for whatever reason, you don't want to do ablation, okay? Okay. Okay, so case 5. This is a video. I hope it plays. Okay, so just look at this video. So obviously someone is having what? Tachycardia, regular, right? It's a baby, by the way, newborn. It looks wide-ish, right? Okay, so wide, complex, regular tachycardia. And they are giving adenosine now, okay? Okay, so what happened with adenosine?
Now it's
Nothing.
silent.
Okay,
now silent. Okay.
okay. And then what happened?
Again.
Hello. So, this is a true example. This patient had adenosine, and when they called me, what they told me? Nothing happens. Okay? But again, something happens, just happens transiently. Okay? So when you see wide complex tachycardia and someone tells you nothing happens, you think of VT, right? But again, you cannot trust if people saying nothing happens, because this is a life example. Okay, that's a true example, true story. They called us, nothing happens. And then when I told them document the rhythm strip, they were unable to print. I told them just take a picture or video, and this is what happens. And they still said nothing happens, Okay. Okay. So now, how is this helpful? So now, wide complex tachycardia terminated into sinus and a different QRS, صح?
Yes.
Okay. So, was it a VT? Yes or no?
No.
I mean,
No.
unusual for VT to terminate with adenosine. Everything is possible, but very unusual. So don't say VT is like, right up front, right? Was it antidromic SVT? Possible or not possible?
Possible.
Possible. But is there WW? I mean, just looking at this, I know it's difficult to see, but do you think there's WW?
No, doesn't look like it.
No. Okay. Possible, but very I don't think so. صح? Now, is it SVT with aberrancy? Possible or not possible?
Possible.
Possible. صح? Is it sinus tachycardia with aberrancy at 100 to 70?
Yes.
No. Sinus to 70.
100 to 70 متولي.
Sinus. لا, no.
ده في جنب.
خلاص
I mean-
bingo. So it's SVT with aberrancy. Easy. صح? Okay.
Yes.
The white comment went to narrow complex sinus SVT with aberrancy. Okay, very easy. That's her ECG. It's a funny ECG, but left bundle branch block ECG. So when you have left bundle branch block, typically you have left axis deviation and positive R and V6. and negative deflections V1. So that's left bundle branch block SVT, which is not very usual. Okay. Okay. Anyways, okay. So that's a baby, by the way. Okay. So again, it was a wide complex tachycardia. Patient was stable, regular. So you're going through this route, صح? And then you want to give adenosine, record, and then if it converts into sinus rhythm, it was a SVT of some sort. Okay. And then because there's no WW, so it's not anatomic SVT, it was aberrant SVT. Okay. If there's no change, then you have to suspect VT, assuming that the technique was good. Okay. Okay. Yalla, we're running late. Case 6, 3.5 years old, palpitations. This is definite no adenosine response. Okay. Good technique, documentation of no response. How do you describe that ECG, by the way?
wide complex tachycardia.
Hello.
Regular and monomorphic.
متولي
Regular and monomorphic.
always try to say regular, and it makes a much of a difference. Okay.
Yes.
Regular, wide complex tachycardia. Excellent.
Yes.
Okay. Okay, sorry. So when you have regular wide complex tachycardia, if you remember the differential, where is the differential? If you remember, you have this differential, صح? Just a second, sorry. Where is it? Okay, regular.
Yes.
Here, sorry. Here. Oh my God. Okay, regular tachycardia wide regular. You have oh, sorry, one more. Oh, did I not? Here. So tachycardia wide regular sinus with SVT with aberrancy, antinomic tachycardia or VT. Okay, and we definitely are sure there's no adenosine response. So usually these two are out of the picture.
More VT.
So more VT.
Yeah.
Okay, is it? Okay. So how would you describe? I know you said regular. I know you said wide complex. Can you describe it further, like in terms of axis and bundle branch block morphology? And is it left axis or right axis?
Left axis.
Left axis. Is it right bundle or left bundle?
Left.
I hear
No,
left. I heard Shema left. It's right.
I think right.
Right,
We just said left. We have V6.
Ah.
Okay. Okay. So right bundle, left axis deviation. What comes in and VT for sure? Are you
Yes.
aware of any type of VT that causes left axis right bundle? That in pediatrics, benignish VT. It's a difficult question, but I'm sure you heard of it.
Yes. Catecholamine induced.
No. Fascicular. Mariam is fascicular Belhassan VT. You heard of it before?
Yeah.
Fascicular VT, okay?
The verapamil sensitive.
Yes, verapamil sensitive. Excellent. Okay, so we gave verapamil. So this patient was given amio before.
Yeah.
He called me, and then we gave verapamil. I told him, just give verapamil. We gave verapamil at 6:14 a.m. Okay, 6:54 a.m. He changed, her rhythm changed. طبعا what do you see now? عباس ولا كلمة قلت يعني. Don't be shy, Abbas. Where are you?
Long PR.
First degree heart.
Regular, first degree block.
Okay. زين. So first degree صح؟
First degree heart block.
حلو. First degree heart block. زين. وطبعا خلاص assumingly sinus rhythm صح؟ P wave pulse in lead 1.
Yes.
Okay. AVF. Okay. Anyways. So has first degree. I don't know why I had first degree. They later normalized. I think because of the combination amio verapamil. Okay. It was not a high dose verapamil and wasn't high dose amio, but for whatever reason he had first degree. Anyways. Okay. So this is an example. Wide complex, stable, regular. We gave vagal, no change, and there's left axis right bundle. So that you want to give verapamil usually. Okay. طبعا. Otherwise, if you have VT in pediatrics, not your typical left axis right bundle branch block, sometimes it's because of channel inherited arrhythmia, cardiomyopathy, there's a scar, There's congenital heart disease, tumors, myocarditis, electrolytes, or idiopathic. These are your main differential, okay?
Excuse me, Dr. Muhammad, would you give isopten to such a patient? I believe he's below 1 year with the white
He's
complex.
3.5 years. He's 3 point, not 1 year.
3, it's okay. Oh,
Yeah.
yes.
No, don't give before 1 year.
Ah,
Okay.
I heard it.
Anyway, yeah. So anyway, so you have differential. Obviously, if it's VT, that's not your usual, fascicular, or there are VTs that are common, like RVOT VT, like outflow tract VTs. These are common, usually benign. But otherwise, if his VT is not a fascicular or outflow tract VT, you have to think of the arrest, tumor, congenital disease, scar, cardiomyopathy, something weird, especially in pediatrics, okay? Ischemia, but we don't see ischemia, obviously, okay? Okay, so finally, take home messages, record adenosine, please. Don't give adenosine for irregular white complex rhythm, okay? WW might be life-threatening, okay? And ablation is often recommended, okay? And then the algorithm that I show, you always have to have organized way of thinking and try to have your own algorithms in mind. You can use mine, you can use whatever algorithm. And I think I misspelled algorithm here. Is it with an I or with an Y? I don't know. Is it I or Y? Anyways.
Why?
Algorithm.
It's
Y.
Y?
Why?
Not
Why?
I. Oh, okay.
Why?
Anyways, so be organized. And once you're organized, you have a differential, like we said, usually you will just get the diagnosis, okay? Yeah, look, it's an I. Mariam says, Mariam is, so I think it's an I. So, anyways, is it? You have to keep, be organized in your mind and approach the ECGs. And once you're organized and approach an ECG in a organized way, you most likely should be able to get the diagnosis. Okay. Okay. خلاص. Questions, guys. So those who are quiet, was it confusing? Super easy? You're just shy, Can you just say something? مثلا عباس, was it good? عباس?
تسلم ايدك يا دكتور محمد فيري نايس ليكشر.
Okay,
هي
thank you.
الفكره الليكشر ديت بعتبرها تكمله للحاجات اللي كانت سقطت مني في محاضره عندك على اليوتيوب
Yeah.
برضو بتتكلم على الاس في تي. دي تكمله للحاجات اللي هي سقطت مني، يعني دي مور سمبليفايد اكتر من التانية. يعني المره اللي فاتت كان حتى دكتور بابو نفسه كونفيوزد فالمره
كم
دي
مرة
لا.
طافت تكتب باب
آه،
ما حضر
لا كان حاطط
دي
فيها.
طيب دكتور محمد.
من زمان دكتور باب بعدين قطعنا ما قام
آه.
يحضر ما ادري ليش عموما yeah anyways yes so Natalia, she's asking questions. Yes, Natalia, the first degree heart block was transient, then normalized. Okay.
One question to Mohammed, please. You mentioned in one of your slides oral lidocaine. Can you give more data about this?
The maxilitine, it's drug called maxilitine, which is like equivalent to oral lidocaine but oral. We have it. We don't have it, but I have. I bring it. I do have a couple of bottles from India, but we don't have it here. We have to purchase it from India. It's it's difficult to get. In Egypt, I don't think you guys have it. I tried to bring it from Egypt. I don't think you have it. Anyway, so that's maxilitine, which is used for long QT patients or for patients with VT that are, for whatever reason, you cannot ablate or not on ICD, and very unusual patients. But most of the time, you don't need it because patient has, for example, ICD or underwent an ablation or is very well controlled on beta blockers. The indication for maxilitine is very limited. One of them is long QT, and the other is just like the weird case that we had, that I show.
The dose is 1 per kg or?
No, it's Q6 hours, and I'm trying to remember the dose. I don't use it very often, but it's not 1. It's like more. I think 3 to 5 per kg. Look it up, but I don't remember the dose. But it's I think I remember correctly. It's not 1 per kilo, I don't think. Not like it's not like the 0.5 to 1 per kilo IV lidocaine. It's like oral.
Mhm.
And the problem with it, you have to give it 3 times a day. So it's it's like short acting.
Yeah.
Okay.
Thank you.
I think it was 3 to 5 milligrams per kilo per day, but I don't remember. Don't quote me on this.
Yeah.
Okay.
Thank you very much.
Okay. Thank you guys.
Thank you.
متولي خلاص? Questions?
خلاص.
Okay. So stop share.
And stop recording.
Yeah.
Thank you so much.
Okay,
Thanks
guys.
so much, Dr. Muhammad.
Okay.
It was very nice lecture.
Thank you.
Bye.
Bye.